Good evening. My name is Cecilia Thompson, Member Services Manager at BARP. I will be your moderator for this evening's session. Thank you for joining us for this evening's session, Understanding Colon Cancer, presented by Dr. Brandon Griffith, Dr. Alex Doyle, and Dr. Sahle Griffith from the Caribbean Colon Cancer Initiative. Before we begin, just a few housekeeping matters. This meeting is being recorded and will be shared on our YouTube channel. If you prefer not to appear in the recording, please turn your cameras off now. All participants will be muted upon entry to ensure a smooth experience for everyone. The meeting will be open for questions during the questions and answer segment. At that time, you may either place your questions in the chat or use the raise hand feature located next to the chat button in your Zoom app or browser. With that, let's get started. It's my pleasure to invite our President, Madam Marlene Rice-Bowen, to deliver the opening remarks.
Good evening, all, and thank you very much, Cecilia. Vice President of BARP, Eric Smith, and other members of the Board of Directors of BARP. Our presenters, Dr. Brandon Griffith, Dr. Alex Doyle, and Dr. Sahle Griffith. Management and staff of BARP. Members of BARP, a pleasant good evening. It is my pleasure to welcome everybody, our doctors, healthcare professionals, members, and guests to this important presentation on colorectal cancer. We are especially honored to have with us our dedicated medical practitioners whose expertise, experience, and commitment, and I want to reinforce the word commitment because these gentlemen are indeed committed to patient care. They continue to make a meaningful difference in our communities. Gentlemen, your presence here this evening underscores the importance of collaboration, education, and awareness in the fight against colorectal cancer. Colorectal cancer remains one of the most common cancers worldwide, and it's only recently I think I heard another doctor expressing the view about colorectal cancer and that it is curable if it's caught early. And I also recall, I think it was last year, that we were privileged to sit at the feet of Dr. Sahle Griffith when he spoke about colorectal cancer and the detection methods and how easy it is to be detected. And, you know, the secret is prevention. And last 2 weeks ago, we hosted a session here on our Zoom platform on preventative care. So this evening, we are focusing our lenses on colorectal cancer and understanding colorectal cancer. So this evening, we're going to get a lot of information. I know for sure that none of these doctors want to frighten you, but what they want to do with us is to stir us up that we act. Because if we don't get the information and if they don't pull at the right point, you know, the doctors know exactly how to speak to us. If they don't pull at the right point, apply the pressure correctly, then we will all leave this presentation this evening as we came, just figuring that they're talking about somebody else and not us. So BARP, we are committed to ensuring that all members are afforded the opportunity to learn all about health and about prevention. And as I close, I know this evening we are honored to have among our guests our visiting executives from Beacon Insurance, Kevin Davis and Monique Mitchell, and they're on this call as well. And it's important that they be here because they're all insurers, so they want to hear what's happening. So to everyone, ladies and gentlemen, I want you to relax. Yes, I want you to make notes. And yes, do not leave this meeting this evening unless your question has been answered. So without any further ado, again, BARP presents Understanding Colorectal Cancer. Good evening, all.
Ms. Thompson, you're still muted.
Okay, thank you. You can hear me now?
Yes.
We can, yes.
Okay, sorry about that. Thank you, Madam President. The Caribbean Colon Cancer Initiative is a research-based organization founded in February 2021 by Dr. Sahle Griffith, Dr. Alex Doyle, and Dr. Courtney Chase. The founders discovered there was a dire need for the awareness of colorectal cancer within the Caribbean, and also adequate access to preventative measures for colorectal cancer. Additionally, the founders were keen to use the platform of the Caribbean Colon Cancer Initiative to fill a gap of literature and target research on Afro-Caribbean descendants as it relates to colorectal cancer. The Caribbean Colon Cancer Initiative is dedicated to minimizing the cases of colorectal cancer in the Caribbean and providing an information portal for those seeking data on the current status of colorectal cancer within the Caribbean. The CCCI thrives on its core value of integrity, compassion, and collaboration. Your presenters this evening are Dr. Brandon Griffith, Dr. Alex Doyle, and Dr. Sahle Griffith. Doctors, over to you.
Thank you, Cecilia. Can you hear me okay?
Yes, I can.
Okay, great. So this afternoon, as was said before, we're going to have a discussion, and it should be an interactive discussion on colorectal cancer. To begin, I'm going to give a short presentation on colorectal cancer and what every family in Barbados should know. There is a short video at the beginning of the presentation. Hopefully you can hear the sound of the video.
Colon cancer is one of the killers all over the world. In fact, it's the third most common killers among all the cancers.
The number of colon cancer cases in U.S. adults under the age of 54 has sharply increased over the last decade.
Now, new data shows the number of under 50s being diagnosed with bowel cancer is increasing worldwide.
I'm Professor Olusegun Kalatiche. I'm a professor of surgery at Obafemi Awolowo University at Ile-Ife, southwest of Nigeria.
Studies are still establishing the main causes of bowel cancer, but it's thought poor diet, ultra-processed food, and obesity and lack of exercise may be factors.
We must continue to change the practice. We must continue to train, and that's what I've seen in the last 3 days. Junior colleagues, residents were trained on the act of using endoscopy. So wherever they find themselves, they can continue to help to make the diagnosis early. And if you are able to diagnose them, identify those cancers early, you can cure them. Believe you me, cure is cheaper and it is more rewarding if you diagnose those cancers early. However, most of the cancers that we see in the Caribbean country and in Africa, they come when the treatment is unrewarding and it's more expensive.
CCCI was formed basically about 5 years ago. It was encouraged by a study done by PAHO in 2016 that pointed out that the colon cancer was expected to rise by 60% within the next 10 years. That was between 2016 and 2026. And that the Caribbean in particular had major problems with regards to colon cancer screening. with Barbados having the second worst survival for colon cancer in the PAHO region.
One of the big questions is, well, what does colon cancer screening look like in Barbados? What would a program look like? Can we use the evidence to inform a colon cancer screening program or colon cancer treatment or the application of laparoscopic surgery like we practiced last 2 days? We need the research to inform that. And I think having a dual pillar approach is exciting. And then you can see how the two pillars start to weave and cross-pollinate. That's exactly what happened when we met Prof, which is what is so exciting, is that was research out of Nigeria that showed and quantified a dearth of access, a dearth of qualified endoscopists. The logical extension of that research was a clinical masterclass or a clinical component. That's how we met, and so we met at that cross-pollination between the research and the clinical, and I think we're going to see that here between Dalhousie and University of West Indies and the Colon Cancer Initiative, which is super exciting.
Colon cancer is one of the killers all over the world. In fact, it's the third most common killers among all the cancers.
So coming here to Barbados made me realize that medicine is continuous, it's not stopping. That is why these conferences are so important to attend.
This workshop was aiming to fulfill the deficits within the Caribbean region in both minimally invasive surgery and also endoscopy. So the course was designed to give faculty members and residents an interactive session in both dry and a wet lab.
But I must say that they have taken it very high, because we do colonoscopy training, but they combine colonoscopy with minimal access training, which is fantastic for the past 3 days. Not only that, they brought a medical student to come and see what we are doing, so as to be able to generate interest in surgical practice. That, I believe, we also do something similar, but not around the same time we are doing the training. But I think this is fantastic.
So that video helps to illustrate why we were formed back in 2021. So we're a nonprofit organization created to reduce the incidence and mortality associated with colorectal cancer. And we have 3 main goals. One is to facilitate Caribbean-focused research surrounding colorectal cancer, and specifically colorectal cancer genetics within the Caribbean region and in the Afro-Caribbean region. Additionally, we want to improve the quality of health care that is delivered surrounding colorectal cancer from every aspect of the care of the cancer patient, from screening to survivorship. And then the third realm, and one of the reasons that we're here and graciously accepted the invitation to join BART in this endeavor, is public education, because we wanted to increase the public awareness surrounding colorectal cancer. These are some of the members of the team. This is Nurse Esther Sargent, our health promotion nurse, and Dr. Brandon Griffith, who you will hear from later. And Dr. Sahle Griffith, as was said earlier, was one of the founding members of the Caribbean Colon Cancer Initiative. So why are we talking about it? And it bears repeating that it is one of the most common cancers worldwide. And the most important point of it is that it's actually often preventable. It is also highly treatable when it is found in the early stages. And with this knowledge, we hope to change the trajectory of colorectal cancer in Barbados. So within our region, and specifically with respect to Barbados, the majority of the patients that we see, unfortunately, with colorectal cancer present at stage 3 and stage 4 disease, over 60% of the patients that we see. And stage 3 and stage 4 disease, to break it down, means that it has spread outside of the colon. It is no longer considered early stage disease. And then you would need additional treatments to try to cure the cancer. Additional treatments may be in the form of chemotherapy, or in some instances, immunotherapy, and depending on if it's located in the rectum, even radiation treatment. So what we want to do is to prevent you from presenting at that stage and screening is the vehicle through which we can do that. And it is through these endeavors that we're hoping to increase the amount of screening that occurs here currently on the island. So let's take a step back. What really is colorectal cancer? Basically, it's cancer of the colon and the rectum. And what really is a cancer? It is a tumor, a mass that arises from the inner lining of the colon, what we call the mucosa. And these usually start as small growths called polyps. And then these polyps over time turn into cancer. For most people, that time interval from normal mucosa to polyp to cancer is about 10 years. So it is a 10-year period in which hopefully we can intervene to be able to either catch a polyp or early cancer. And through colonoscopy, one of the screening methods, remove it and prevent it from developing into full-blown cancer. So screening, therefore, can stop cancer before it starts. And colorectal cancer, based on the way it is formed, what we call the pathophysiology, is one of those cancers where screening can be very beneficial. So just to help to visualize it, this is what we call the large intestines. So this is the large intestine. It starts on the right side of the abdomen in the cecum, and then it goes across up by the liver, across under the stomach, in the transverse colon, over to the spleen on the left side, and then it comes down on the left side of the abdomen to then form the rectum, and then through the anus. Obviously, this is where the stool passes. And this is the change that occurs in patients that have colon cancer. There is normal mucosa that may form, that is present, but then you may have changes due to genetic mutations within the mucosal lining of the colon, which then predisposes you to getting adematous polyps forming. And then this can progress through what we call severe dysplasia, which is a precancerous lesion, then into full-blown cancer. And then depending on the depth of invasion of the cancer through the 4 layers of the bowel wall, then that determines the stage of the cancer, in addition to where the cancer may have spread to, whether it has spread to what we call the waxen kernels, colloquially here in Barbados, that is stage 3 cancer. But if it has spread to the lining of the abdomen, to other organs outside of the colon, that is then stage 4 disease. Unfortunately, for the majority of patients, when they present at stage 4 disease, it is not in a curable state, and that is why we want to prevent it from happening and reaching that stage. So who is at risk? Generally, anyone with who is over the age of 50, we would advocate, usually we were advocating for persons to have screening done, but that age is actually being lowered to 45 because of the increasing incidence of colorectal cancer in the younger and younger age group. So age is a risk factor. Family history is another risk factor. And that is associated with clustering. So you may have certain families that have a predisposition to having colorectal cancer, specifically those with hereditary syndromes. And then there's certain other conditions within the bowel itself, such as inflammatory bowel disease, the ulcerative colitis or Crohn's, that predisposes you to colorectal cancer, puts you at a higher risk. And then there are other things like poor diet, obesity, inactivity, smoking, and alcohol use. And I'll go into this a little bit more. So when we talk about colorectal cancer in Barbados, what is the alarming figure is that in 2022, based on data from the Barbados National Registry, there were over 100 deaths related to colorectal cancer. And the age-standardized incidence of colorectal cancer in Barbados is about 25 per 100,000. And that ranks us about 3rd within the PAHO region in terms of incidence. And unfortunately, associated with that is we are ranked about 2nd in terms of mortality surrounding colorectal cancer. And the mortality surrounding the cancer is driven by the late stage of presentation of the patients. And that is really where we want to change the trajectory. So as I said, there are risk factors that I stated earlier can actually be divided into modifiable risk factors and non-modifiable risk factors. So the modifiable risk factors are things that you can actually change. The non-modifiable risk factors, unfortunately, are things that we can't change. Age is something that we can't change. We're all going to get older. In terms of your family history and genetic makeup, I know sometimes we may want to change our families, but unfortunately, we can't. Our genes are our genes, and science hasn't caught up to a point where we can change our genes just yet. So persons with inherited syndrome, such as Lynch syndrome, familial adenyloid polyposis syndrome, all put you at an increased risk of developing colorectal cancer. And based on this risk, your screening schedule for cancer is different than persons who are average risk. Now, we want to concentrate on those modifiable risk factors because those are things that we can actually change. And they surround a lot of lifestyle changes. So things such as your diet. So diet high in processed foods, red meats are bad for you and can predispose you and increase your risk of developing colorectal cancer. Alcohol use, inactivity, obesity, sedentary lifestyle, which goes with inactivity. All of these things put you at an increased risk for colorectal cancer. So you know there's the mantra, and everyone says it, that there is a surge in the non-communicable diseases. This is part of that spectrum as well. So maintaining a healthy weight helps to reduce your risk factors, in addition to smoking cessation. So these are some of the things that we can do to change our risk profile with respect to developing colorectal cancer. There are, however, some warning signs if we should unfortunately be diagnosed or there's a suspicion of colorectal cancer. And some of the things that you need to look out for when you're generally thinking about your own health is blood in your stool. And sometimes we may have blood in our stools on one occasion and we forget about it. And then it occurs some months later, we forgot about the first episode. So then we think that this episode might be the first episode and we ignore that sign. But it is an important point to note that if there's blood in the stool, that is abnormal and you should check out with your doctor for them to figure out exactly why that is happening. If you have a change in your bowel habits, this is one of the more significant signs that we look for and we ask patients about. So normally you would have a certain quality of your stool. Stool comes out in a certain size. And if you notice that that has changed over time, the consistency of the stool has changed, the amount of stool that you're doing has changed, it's time to really speak to your doctor, have a discussion, and see what other symptoms you may have that you may not necessarily be putting together, but that your doctor, after hearing a full history, may be able to put together. Other things such as abdominal pain, unexplained weight loss. So it's all well and good if you're actually trying to lose weight and you're exercising and you're successful on that plan, that's great. But if you're not and you find that your clothes are fitting looser than normal, I think it's time to speak to your doctor, have a discussion. And then fatigue. That can actually be a sign of what we call anemia, which is a low hemoglobin level due to you're losing blood somewhere within either your gastrointestinal tract or there's some other abnormality. So that is something also that needs to be investigated by your doctor. But as I said, the best thing that we want to promote here this evening is prevention. And prevention starts with you. And these are the things that we spoke about, the modifiable risk factors. So changing your diet, increasing the amount of fruits and vegetables, and your fiber intake is very important in trying to change the trajectory of colorectal cancer and your risk profile. Having regular exercise, maintaining a healthy weight, avoiding smoking and limiting alcohol. All of these things play a role in decreasing your risk. So what we want to do is to catch any issues that you may have at an asymptomatic stage when you actually don't have any symptoms, when you don't have any of these warning signs. And this is how screening then can save lives because it detects the cancer early. It can prevent a cancer from actually turning into a polyp and then progressing into a cancer by removing the polyp. And there are certain tests that can be done to help us to determine who may need the gold standard test, which is the colonoscopy. And there's some stool-based tests, which we'll talk about a little later, which can help us to, as I say, triage those who really would benefit from having a colonoscopy. The recommendation for you for average risk persons who have no risk factors that I outlined previously for colorectal cancer is actually decreased now to the age of 45. So you should start your screening program for colorectal cancer at the age of 45. And this is based, as I said, on evidence from first world countries and other regions of the world, which has shown that there is a rising incidence of colorectal cancer among a younger and younger age group, persons presenting in the 30s and early 40s with colorectal cancer. So this may be a bit of a busy graphic. I'll spend a little time on it so that we can go through it bit by bit. So your screening test and your time for screening is based on your risk. And as I said, if you have average risk, so you have no risk factors for colorectal cancer, there's no family history of colorectal cancer, you've never had a polyp removed, don't have a personal history of cancer, you don't have any of the inflammatory bowel disease conditions, then you should start your screening at age 45. If you have an increased risk, so you have a family history, and specifically a first-degree relative with colorectal cancer, it depends on the age at which they were diagnosed, or the youngest family member was diagnosed with colorectal cancer, and your screening should really ideally start 10 years before the youngest person was diagnosed with cancer in your age group. And then there's the high risk group, so persons who may have genetic syndromes. One of the more common types will be Lynch syndrome, which about 3 to 5% of colorectal cancer patients have it. We don't routinely check for it unless there's a high level of suspicion. That is some of the things that we want to change as well, because there are certain tests that you should do to try to determine your risk of having Lynch syndrome. So based on your risk profile, that determines then when you should have your screening done. And what are the screening options that we have? So as I said, the gold standard test is colonoscopy. The issue with colonoscopy is that it is not readily available. It is limited by the capacity of the healthcare system to offer colonoscopy. And I'm not sure how many members within the group might have tried to access a colonoscopy, especially in the public setting. And just to get an appointment, sometimes to go to the clinic, there's a backlog of maybe 1 to 2 years. So trying to access colonoscopy is a difficult endeavor in the public setting. It may be easier in the private setting, but then there's a cost attached to that as well. And I heard the president allude to insurance companies in the audience. I'm not sure if it has changed or it is changing, but insurance companies financing screening via colonoscopies has been a challenge in the past. Things may be changing, hopefully, but that is something that you need to look at. So if we're saying that there's a gold standard test, but everybody can't access it, then we need a way to triage who should access this scarce resource. And it is through a stool-based, and I would say a FIT test first screening strategy that you can identify and triage those patients who may more benefit from having a colonoscopy done. So FIT test is another stool test, and Dr. Brandon Griffith will go through in one of the later presentations what actually entails in the FIT test. And this should be done every year. And like I said, it's best for persons who are asymptomatic, and it detects blood within your stool. So then if you have a positive test, you are then triaged to go and get a colonoscopy. There are other stool-based tests, such as Cologuard, which is a multi-target stool DNA test. This is usually done every 3 years if the initial test is negative. And this looks at certain DNA fragments that may be present within the stool. The issue with Cologuard is that it's not readily available and it is highly expensive. So for a national screening project, I don't think that this really will be an appropriate test. It may be appropriate for an individual who can actually afford it, but it's not something that we would generally recommend for a national screening program. The other options then are flexible sigmoidoscopy, which is akin to the colonoscopy. However, in flexible sigmoidoscopy, you don't actually examine the entirety of the colon. At most, you can get up to the left side of the colon that I shown on an earlier slide, where you can get as high up maybe as the splenic flexure if the patient can tolerate it. This is usually paired with one of the stool-based tests. And then there's CT colonography, which may be a less invasive test. You do have to do a bowel prep for this test. And then you can undergo a CT scan and it can detect polyps and potentially cancers. Small polyps less than 5 millimeters, however, CT colonography would fail in that regard. So there are limitations to that, even that test. So these are the screening modalities that we would really recommend for persons on the island and on the call currently. And the colonoscopy is the gold standard test because you can remove a polyp which may be present and arrest the growth of any developing cancer. Or in some instances, if you do find an early cancer, depending on where it is and the morphology of the actual cancer, you can do endoscopic procedures as well to remove the cancer. So colonoscopy is the gold standard, but like I said, there is a limited capacity for colonoscopy on the island. We have certain ideas about how we can increase that capacity. One of them was through training programs, which was alluded to in the video that I showed at the beginning of my presentation. So I think this is the biggest issue that we have when it comes to screening, overcoming fear. Screening has been shown to be safe. As with any procedure, there's a risk. And the major risks that we warn patients about for persons who may undergo a colonoscopy is the risk of perforation. But that risk is minuscule. So is less than 1 in 1,000 patients that may occur. And majority of the cases, even in that rare occurrence, they have microperforations. They don't need any other intervention apart from bowel rest, meaning that they don't eat and drink for a couple of days. They stay in hospital and are observed. Sedation is used for colonoscopy. For some of the other stool-based tests, you can do those things at home. You can return the result to the office or a lab, and then you can get back a result and then determine whether you need to go on to further testing or not. If the test is negative, then you are reassured, depending on the type of test you do, either for 3 years or 1 year, then you have to repeat the test again. So early detection saves lives. The issue is, are you going to do the test? And like I said, overcoming fear, there's stigma associated with cancer in general. And then there is, and I would admit, there's a ick factor when you have to do with anything dealing with the stool. But if you think about it from a rational standpoint, if you can do a test, if you're able to access colonoscopy or even do some of these stool-based tests, but a colonoscopy, if you're able to get a colonoscopy and it is normal, that can give you, unless something else happens, 10 years of peace of mind that is one less thing that you have to generally worry about. And for me, that is a selling point. There is a fear surrounding having to undergo sedation. And those are things that you can discuss with your doctor to try to allay your fears. But inaction, I don't think is the right step. As we said, the incidence and mortality is so high on an island this small. For us to rank that high, it is alarming. And we really need to do something about that statistic. So for those persons who may actually be diagnosed, unfortunately, with colorectal cancer, your treatment then is going to be based on the stage of the disease. We want to catch it early. If you have to have a cancer, we want to catch it early. And if we catch it early at stage 1 or stage 2 disease, that is where we can have it at a curable stage. The chances of cure decrease as you go from stage 3 to stage 4 disease. So stage 3 disease, the cure rates are about 60 to 70%, while for stage 4 disease, there's in the range of 20% for persons who may be able to get some type of surgery or less even. So we really want to advocate for us hopefully catching it early. And the modalities that are used to treat are surgery, where we have to take out, and depending on the way that we do that, we advocate for you having a minimally invasive approach once it is safe to do so. A minimally invasive approach to take out that portion of the bowel which may have the cancer, so that we can look at it under the microscope, examine the bowel itself, look for the level of invasion within the layers of the bowel, and then look for any spread outside of the bowel itself so that we can get an accurate staging. Then we can determine if there's other treatment necessary. And the other treatment that may be necessary would be in the form of chemotherapy. And then there's radiation therapy as well. There's another gamut of therapy that is not always available locally, but it is something that is potentially revolutionary in terms of the treatment of not only colorectal cancer, but a lot of other cancers that are out there, and that is immunotherapy. Where I trained at MSK doing my fellowship, they actually were able to do one of the landmark trials looking at the usefulness of immunotherapy in actually reversing the cancer and the development of the cancer, where you had a clinically complete response in their cohort, which was a small cohort for the initial study, about 20 patients with rectal cancer. But that is showing some actual promise throughout the medical fraternity, and is one of the rich areas of future research. Hopefully, we'll look to get involved in that type of research so we can bring that treatment option to our patients here locally. So if we catch it early, like I said, then many patients are cured. And that is what we want. So initially, with our screening efforts, we recognize that we are going to be catching some cancers, and the hope is that we're going to catch those cancers at an earlier stage, earlier stage. As screening becomes more prevalent throughout the country, then we're actually going to be able to hopefully decrease then the incidence of colorectal cancer. And this is all of the work that we are doing here today, and all the work that we do day in and day out to be focused on cancer care and colorectal cancer care throughout the island. So life after treatment. To be honest, for early cancer, or even patients with stage 3 cancer who've completed chemotherapy, many may return to normal life. You do, however, have to do follow-up, and follow-up is what we call surveillance. So we, during that time period, looking for the cancer and seeing if it will come back. So there are blood tests that we do. There's imaging in the form of CT scans of the chest, abdomen, and pelvis that we do on a periodic basis to look and see if there's any evidence of a return of cancer. Because again, if we can catch these things early, that portends better for your outcome. And the other important part of a treatment for patients who are diagnosed with cancer is emotional and spiritual support. That plays an important role in person's ability to actually come out on the other side of a cancer diagnosis. And that is one of the things that we don't really pay that much attention to. That is changing slowly, but that is one of the other important factors that we need to look at in terms of the emotional and spiritual support that we actually offer to cancer patients. So this was actually a presentation that was for initially a church, and I have here how the church can help, but how can civic society, I would say, help? Encourage screening, talk to your friends. If you're at the rum shop line in, 1, avoid drinking any alcohol, but 2, as you're talking, playing dominoes, have a discussion about screening. Support anyone that you may know who has a cancer diagnosis. We are obviously looking to promote healthy living, so lifestyle modifications. And it's easy for me to say and put it on a paper, but that is one of the more challenging things for anybody to try to undertake, because you develop habits over decades, and it's not easy for you to just flip a switch and change one day. So it takes small incremental changes day by day until those changes that you have made then become habit. And then reducing the stigma. I think the more we talk about cancer the more that it becomes part of normal conversations, that will help to reduce the stigma associated with cancer in general. So the key take-home message from my part of the talk is that colorectal cancer is preventable. Screening can save lives. Early treatment, if we catch it early, can work. And faith and action go together. So a lot of patients do lean on their faith, and you have patients coming to you saying that they believe in a miracle, and sometimes they forego treatment because they're looking for that miracle. But as this quote says, for as the body without the spirit is dead, so faith without works is dead also. So for me, I interpret that as God may send your miracle in the form of persons that he puts in your life to help you to get through a cancer diagnosis, whether that may be a doctor, your medical oncologist, your surgical oncologist, even your family, a friend. All of these persons can help you to achieve that miracle that you're seeking. So just don't lean on your faith. Also take action to action the miracle that you're looking for. As I close, it will be remiss of me not to mention some of the activities that we're having throughout the month. And this is towards raising awareness around colorectal cancer. So we're having an open day on the 6th of March at the Queen Elizabeth Hospital on the ground floor, and that's between 10 and 2. That is on Friday. We're hoping to have a multidisciplinary quiz. We have the March 10th, but it will actually, we're hoping to have it televised so that it will actually be aired on Channel 8, so you can look out for that. And then we're also hosting a health fair at Golden Square on the 13th of March. And then some of our bigger events are a colon cancer awareness walk, which is supposed to happen on Sunday, March the 22nd. Starts at 4 p.m. Again, we're starting at Golden Square. And then there's the Uniformed Services football match, which will occur at Weymouth. So I'll be looking forward to seeing all of you who are online in person at each and every one of these events. If you have any questions, you can take down our contact information, and we will be happy to share any pertinent information or answer any questions that we can't answer on this live. We can answer offline as well. And with that, I can turn it over to Dr. Brandon Griffith, who I think also has a presentation to give.
Good night, everyone. Thank you very much, Dr. Doyle. All right, so good night, everyone. My name is Dr. Brandon Griffith, the Junior Research Fellow for the Caribbean Colon Cancer Initiative. And I'm just going to talk about some of the data we have collated, as well as Project Scope, Barbados National Endoscopy Advancement Initiative. This is the phase 1 of this initiative. And the reason why we started it was due to the burden of disease of colorectal cancer in Barbados. So as Dr. Doyle mentioned, he mentioned the regional data or statistics, but Barbados ranks 8th highest for colorectal cancer incidence worldwide. Our ranking sits as per age-adjusted death rate for colon cancers as per GLOBOCON data in 2022. So this was formed as an opportunity for screening, also diagnostic colonoscopies. In this month, well, in the month of November, which was Independence Month, as everyone knows, we had a Caribbean Society of Endoscopic Surgeons conference. So we sought the opportunity to give back to the country during that period.
Sorry, Brandon. I think they're saying that the volume is a bit low. I'm not sure if you can speak up or raise the volume on your end.
Can you hear me better? Hello?
It sounds fine to me. I think they can put it in the chat if they're hearing better.
Okay. All right. So the reason why we formed this as an opportunity for screening, and we used it to provide free screening for essential public service workers aged 45 and older, without whom the country could not run. This would include the Barbados Defense Force Legionnaires, Police Service, Barbados Nurses Association, the Postal Service, and prison officers, as well as sanitation service. So how did we carry this out? And before I go into the details of how we carried it out, I just wanted to let you know I'm going to show you a short video of one of our screening tests previously mentioned by Dr. Doyle. This is a fecal immunochemical test. There's going to be a artificial sample seen in the video, so do not be alarmed. So we distributed these tests, 320, to these service providers. And the test is a home-based test. This home-based test is cost-effective, non-invasive screening tool, which can detect hidden blood within the stool. It's often an early sign of colon cancer and the development of adenomas or small polyps. So I'll go ahead and show you the video now. So as you can see, there's a box in front of us. This box is our packaging for fit tests that holds about 10. And this package is one that holds one and is personalized for the patients. Inside the package, you can find a demographic card. So I'll just pause it shortly so everyone can take a look. So the demographic card takes your name, your ID, your email, mail address, telephone numbers, home and cell, and your gender. This is important for us to keep track of your record, as well as the data which the Caribbean Colon Cancer Initiative collects. Additional to that, there is a small tube with a reagent inside. So this is necessary for the testing of your sample. A buffer solution then mixes with the sample to detect the blood on the cassette, which will be shown shortly. So here you can see the cassette and the sample bottle. So at the end of this rod, there's a swirl end. What you would do is you take the sample after you wipe at your bottom at the toilet, and you just take a little bit and you put it into the bottle. This is an artificial sample. Do not be alarmed. So when you perform the test, you return the test back to us, and we test it on the cassette, similar to that of a COVID strip if you've ever seen one before. We put a few drops on the droplet area, and then we read to see whether it's false or positive. If the test is an accurate test, there will always be a control line. Once the control line stays alone for 15 minutes, then this is a negative test. If two lines show up, then this is a positive test. If no lines show up, then the test is invalid. So here you can see a solid line. This is a control line. If a line was on the other side, that would be a positive test when both lines are visible. If no lines were visible, then this test will need to be repeated. All right. So as I said previously, 320 tests were distributed in the month of November to these groups. And this was aimed to increase accessibility for screening, especially for our service providers. So from our ongoing studies at the time, we noticed an anecdotal positivity rate of about 10%, anticipating the need for 30 diagnostic colonoscopies if we distributed around 300. So how we carried out this initiative, we distributed these free tests over a course of 1 week. Our aim was to have the colonoscopies done at the Barbados Defense Force. But due to this situation in Jamaica following the catastrophic damage by Hurricane Melissa, our troops had to be placed on dispatch. So following such events, we had to look for alternative. Fortunately enough, we were able to form a memorandum understanding with a private entity called Surgical Solutions Incorporated. And this also allowed us to facilitate this historic initiative within the country of Barbados. Simultaneously, we thought it necessary to seize the opportunity through the Caribbean Society of Endoscopic Surgeons to perform a minimally invasive workshop, first of its kind in the Caribbean region. This was important because, as mentioned by Dr. Doyle, there are various ways in which you can treat colorectal cancer. And one of them are through minimally invasive surgery. And due to minimally invasive surgery being relatively new to the Caribbean region within the last 30 years or so, it's important to introduce our juniors and sensitize them to these kind of procedures as the world is trending towards minimally invasive surgery, even in the form of robotics. So for our results and outcomes, 23% returned to us from this distribution. About 40 females and 43 males, or roughly the same. All of the 83, 21% were positive, giving us a positivity rate of 25.3%, which was different to what we had expected. 19 of these patients had colonoscopies over the three-day period. Out of the 19, roughly 50% of these patients had polyps. Unlike a similar research that came out from Nigeria, where they showed that they had a lot of false positives in terms of the FIT tests, this short initiative of phase 1 Project School actually highlighted that FIT tests may be a very relevant test to our demographics. So over the course of 5 years since the CCCI was established, approximately 1,500 FIT tests were distributed. To us came back 386, 244 were negatives, 138 were positives, and 4 were invalid. We saw a negativity rate of 63.21 and a positivity rate of 35.75. Even though we had a decreased return rate to what we had distributed, we still see an increase in positivity rate greater than that of 25%, showing that there is a high positivity rate seen in our population. And approximately 50% of these people have polyps, and some of these patients have stage 3 and 4 cancer. So our return rate is about 25%, and attrition rate of 74.27%. And the reason why we have these challenges in terms of return is because sometimes when we distribute free FIT tests, patients may discard them, or they may carry out the test and never actually return them due to the fear of what their results might be. If they are distributed to their physicians, the physicians may protect the privacy of the patient, so we may not actually get these results back to us, despite the patient having a positive or a negative. So when encountering these challenges, we find ourselves with a deficit of information needed to shape and propel policies within Barbados for colorectal cancer screening. So I just want to touch on the points that Dr. Doyle mentioned earlier that we need to address in terms of advancing screening. And I believe that the most important thing here is public health education. I didn't mention it earlier, but all of the service groups, we noticed a higher return from those who had more educational sessions than those who had least. One group who had 4 educational sessions within the year of 2025 returned majority of oral fit tests during project school, whereas the group who had their first teaching approximately a week before project school returned the least. And addressing these stigmas and changes in behaviors is not an easy task, especially amongst men. So we need to continue the education so we can help shape those behaviors and change the environment. So as we continue, we would like to erect more community health promotion programs similar to Project Scope. As I mentioned, is phase 1, so you can expect a phase 2 to come. We like to encourage opportunistic screening, especially for the doctors. Whenever you have a patient that comes to you age 45 or 50 or above, or you found that they have the family history, we urge you to screen them at that time. National public health campaigns. In addition to Project School, we would love to continue training surgical residents and doctors and even nurses in performing minimally invasive procedures and endoscopy, so they're sensitized to the management necessary for carrying out colorectal cancer treatment. And then empowering those who have family members also who have been affected with colorectal cancer, who are fearful for what that may mean for them. We as a community need to continue to support them and support our physicians and nurses in this battle to reach out to the communities throughout Barbados. I encourage them and let them know that they have support in screening for colorectal cancer, because we rather prevent than have to treat. That's a real cure. And with that being said, thank you very much for your time.
I think now we'll ask Dr. Sahle Griffith to bring it home for us.
Bringing it home. Good day, everybody. How you doing? I'm gonna tell you, I'm here. I'm not certain. Is everyone hearing me?
Very
Yes,
well,
we
Dr.
can hear
Griffith.
Okay. So it is interesting. When I was a boy, I used to like watching A-Team. And A-Team, Hannibal used to say, I love it when a plan comes together. And the irony of this particular situation is that this was something that was conceptualized 5 years ago. And the current director of the Colon Cancer Initiative, Dr. Alex Doyle, was the senior research fellow at the time. And since then, he went on to do 2 fellowships in surgical oncology at Memorial Sloan Kettering, which I think is still the premium or premier oncology unit in the world. And thankfully has returned back. And in a sense, where I see the organization has gone over these last 5 years, I can only feel somewhat humbled by the activities. And I must, at this point, mention Nurse Esther Sargent and Caroline Haynes. So Caroline Haynes was probably the 3rd of the junior research fellows. And they began this series of community outreach works that resulted in pushing the fit testing into the community. And as is highlighted by Dr. Brandon Griffith's presentation, the fit testing, we are still having horrible levels of returns. 25% is really very poor. And the scenario is that the more we educate people, the more we get returns on the fit test. And I am happy. Yet again, this group last year, I think, was the first year we partnered with BARP to reach out to who is essentially our target population, because the BARP membership begins at age 40 and above. And even though I am yet to get my BARP card, yes, I think I'm being a little I have qualified long ago for that, but I'm being a little resistant to accepting the position. Yeah. I accept that in our environment, this is the group that we need to touch base with to try to get screening out there, try to get advocacy out there. And I am very pleased with the level of dynamism being shown by the president and her executive to get information out to the public. And it is necessary that we kind of work together to do two things. One, ensure that every BART member is screened for colon cancer via Fit First testing annually. And this should be something I've heard that Beacon is on the call, and it'd be really nice if their representatives can say something. Maybe I'm not going to be too long. I don't have any presentations here, but Fit First testing. Now, I saw that in the chat there was a question as to how much one of these fit tests cost. They cost $50. $50, yes? And annual fit testing. I'm going to be straight with you. We have had some young people who have had advanced polyps via their fit test. I have a young gentleman we did a cells on. That's a combined endoscopic laparoscopic thing. We were able to save his colon but remove a very large advanced adenoma. This was about a year and a half, 2 years ago. And on review, his colon was clear. And it is that kind of success story that we're trying to aim for. So it should be something that the insurance is willing to cover, Fit First testing. And at the point, if you have a positive fit test, then you need a diagnostic test. And of course, that is something that should be covered by any legitimate insurer. Additionally, what we also need is some advocacy for the training of the juniors. Now, in essence, one of the things that we have had to do, because once you do more fit testing, you're going to generate more people needing colonoscopies. So as you can see, we were deluded by our smaller samples to think that it was possibly around 10%. But when we looked at the sample size as a group, as a whole, we found that there's about 25% positivity rate. The fact that the Barbadian population itself has a significant number of persons on the age or over the age of 45, it means that if we have about 50,000 persons who are theoretically being screened annually, we are going to have about 12,500 persons requiring scopes per year. Now, in reality, that's going to be very difficult to do unless you increase scope capacity. And scoping is a complex technique to learn. So you have to basically go about training the juniors in the techniques necessary to be able to execute safely the colonoscopies. So it is something that we would want to advocate for some kind of let's say consistent program for training the residents in surgery and in other maybe clinicians in internal medicine, etc., in endoscopy to be able to have them be able to do the colonoscopies that will be needed in the population. Finally, and I don't want to take up too much time so late in the evening, I think that it is necessary that as a group, yes, we work together to spread the word in the population as a whole. Colon cancer screening is reasonably safe. Colon cancer screening is necessary. And as a person now who has had coming on to 30 years within the medical fraternity, I can speak to the fact that when I was junior, cervical cancer was killing ladies left, right, and center. And the fact that they brought up regular pap smears, they made it popular. We were able to reduce the incidence of cervical cancer, and we were able to reduce severe disease and advanced disease in these population groups based upon early screening and regular and consistent screening. And the same is true for colon cancer. They're both diseases that have a precursor phase that can be addressed and eliminated. And at that point, cancer be eliminated from these patient groups. I know it's not as sexy as cervix, it's not as sexy as prostate, it's not as sexy as breast, but it's also no less dangerous. And I, at this point, hand it back over to Mrs. Thompson. And I would be encouraged if Beacon could say a little word as to, the possibility of being able to offer annual screening for the for the members of BARP. And I yet again would love to partner with BARP in getting some kind of regular and consistent training program in place for the residents to be able to do colonoscopies safely and effectively. Thanks.
Thank you, doctors, for that insightful presentation. Members, the floor is now open for questions. Remember to place your questions in the chat or to use the raise hand reaction features. Any questions?
My hand is up, Cecilia.
I'm not seeing that. Let's look.
Madam President, the floor is open. You can go ahead.
Thank you. And after me, I recognize Hudson. Ines' hand is up as well. Thank you very much, doctors. A very insightful presentation. Dr. Sahle, I recognize that you asked if Beacon was in a position to comment. What I will do, yes, they can, but what I'll do is I will connect them with you tomorrow so that they can have that like a one-on-one conversation with you rather than come on now to commit. But I'm certain they would want to render some level of assistance, but I'm not authorized to speak for them. With reference to BARP, though, our membership base is 22,300. And if you are indeed ready for us, trust me, Vice President Eric is on this call as well. We are ready for you. So let's make an appointment. Let's sit down and see how BARP and how the two of us could work together in the interest of saving lives. Thank you so much. And I will pass on your contact to Beacon. Yeah?
Feel free. Myself and Dr. Doyle.
Certainly. Thank you very much.
Thank you. I have one question though. My question is for Dr. Doyle. Yes, and it is, I've noticed recently appearing in some of the analyses that we're getting appearing of fit testing and M2PK. And I'm wondering, what are your thoughts about M2PK as a screening modality? And is that something that we should be doing, or should we do fit only? Exactly.
Yeah.
Somebody else asked the same question in the group.
Right. So the M2PK, unfortunately, I don't think it is the specificity is good enough for us to be able to use it as a national screening tool. And the issue also is with respect to the cost, because it is actually more expensive as well than a fit test. It is used more in Europe, but it is currently not within the US guidelines as actually a national screening tool. I am, as you were saying, seeing more patients coming with the results. Actually, somebody WhatsApped me a result to ask me if it was a negative result just earlier this week. But it is really not recommended from the major societies as a screening tool for national screening. Persons may use it if they have an issue because it looks at a product of metabolism from the tumor cells as opposed to blood itself. So that may be what is attractive to some persons, but I wouldn't really advocate for it as a part of a national screening program.
But I am my question is, I don't want to get too medical because you have non-medical people on board. But I have seen persons with a negative fit and a positive M2PK. And we handle persons like that, in your opinion?
So, right, the issue, like I was saying, is that the M2PK, they're looking at a metabolite product from glycolysis, really. So, increased turnover of supposed tumor cells. So, in that scenario, because obviously you've done the test, the patient is going to be nervous about the result, although you may not have necessarily blood. I would go ahead, to be honest, and do a colonoscopy or take whatever the symptoms they may have, but do a colonoscopy ultimately. in that scenario to bring some sort of peace of mind to the patient.
Okay, thank you.
And that is probably one of the important points in terms of choosing the correct screening tool, and when we're actually saying that something is screening as opposed to diagnosis. So some of the warning signs and symptoms that I would have spoken about earlier, if a patient actually has some of those things happening, it is at that point that you really are trying to determine whether you need to make a diagnosis for the patient, which is a bit different than screening an asymptomatic patient. So based on the clustering of the symptoms that they have, and this is where interactions with medical professionals are important, that would determine if you should go straight towards a colonoscopy versus doing one of the other stool-based tests first. So in Nigeria, they had looked at some constellation of symptoms in terms of rectal bleeding, and then other associated symptoms such as change in bowel habit, unexpected weight loss, and things of that nature. And when they looked at it, if it was isolated blood in the stool alone or rectal bleeding, because they had other predisposing factors for blood in the stool, that wasn't really that sensitive and specific in picking up a colorectal cancer with that symptom alone. However, if there are other symptoms, then the odds of you having a cancer or even an advanced polyp were 5 or so times greater in that scenario. So all that to say is you need to speak with your medical professional or your GP once you are starting to have symptoms, so that they can then triage you into the right test.
I don't know if you look in the chats, Alex, but there is a question in the chat that says that they were told, I'm not very good. I assume it's a medical professional. I'm not very good with this thing here. So if you can look in the chat, they were told that whilst the FIT test points to just blood, the M2PK suggests blood or polyps more accurately. And I think you might have addressed it, but just to make sure that it is clear. Yeah, so the question is, are you being told that M2PK tests for blood and polyps, while the FIT tests for blood only?
No, the M2PK doesn't really look for blood. It looks for a different thing within the stool. It looks for metabolite product within the stool itself. The FIT test is what looks for blood within the stool. I'm not sure who you would have spoken to about that.
Okay, we have a raised hand by Mr. Hudson Innes. Mr. Innes, would you like to ask your questions?
Yes, thank you, Madam President. Good evening, and good evening to the doctors and to the audience. Thanks very much for this presentation. It's certainly very informative. I'd like to make a correction to information given by Dr. Sahle Griffith with regard to the cost of the FIT test, because Dr. Griffith said that the test is $50. Now, I don't know if he meant $50 US, but I had a FIT test done recently through the Cancer Society, and it was $100 and not $50.
Actually, for our health promotion nurse was messaging feverishly in the WhatsApp. Dr. Griffith should have added from us. It's $50 from us. Others may charge different. From us, that is the cost. So we can speak to the cost that others may have.
Okay, thanks for the correction. But my real question though concerns the cost itself of having the test done, because with regard to the insurance company, now Beacon has not, despite the urging of the doctors, Beacon has not made a comment. But I wanted to ask what was what is currently being paid, what percentage of the cost of the test is currently being paid by the insurance. Is it covered at all? Is a portion of it being covered? And if a portion is being covered, then has there been any change in recent times with regard to the portion that is being covered by the insurance company to reflect the level of urgency that is being shown by or expressed by the medical profession? Because if our situation is so serious and there is such an urgent need for people to be tested, then surely the insurance company should be paying. And if they had been paying in the past, then they should be treating it with a much higher level of urgency, so that our population, particularly the BART population, can be covered to the fullest extent.
Mr. Innes, may I please touch that one, right? And
I wasn't touching it.
Yeah, I understand it. All right. So I am no longer director of CCCI, and as such, maybe I can have a little more leeway in that I'm not constrained by that position. So over the 5 years that we were involved with CCCI, we've had a number of battles with the insurance. And I am going to say that it has improved quite significantly. I would say 3 years ago, we actually invited an insurance company. No, sorry, don't have to tell me. One of the persons that of the body that governs insurance companies in the country, and the president of that particular body, came to the meeting. And I would say subsequently last year, Sagicor agreed to cover the cost of fit testing. So I know for the persons insured by Sagicor, they cover fit testing as a screening modality. It really depends on company by company basis, the percentage and the level of coverage that is involved. The Colon Cancer Initiative, I gather that there is an acknowledgement that there is a need for this particular testing. And realistically, if you look at the colon cancer screening in North America, in the USA, it is actually kind of mandated by the insurers. And it's mandated by the insurers because a colonoscopy where they identify polyps, even high-risk polyps, is far cheaper than a colon cancer resection, which is far cheaper than resection plus chemotherapy. Yes? So in a sense, the insurance companies mandate that for persons over 50, there must be some form of screening modality to maintain your insurance. In Canada, there is a nationalized health service. There's a lower actual screening rate than the USA. But there's also no push by the insurance to get it done, and it's free to the public. But in reality, there's issues with access, and there's issue with let's say desire. Yeah, the same things we're fighting, but they still get at about a 50% of the population being screened. The USA gets to 53%. Canada gets to 40 high. In our environment, we have higher incidences, but we need to spread awareness a little more. So as I said, the largest of the insurers does cover it, and I am thankful for this, and that has come out in negotiations with them. And I really like how Sagicor has come on board in trying to address the issues with colon cancer in the country, and in terms of health promotion with respect to colon cancer in the country. Some of the others are a little later to the party, but I am hoping that they get there soon. And so, in the interest of the negotiations, as you know, I've come to learn that Mrs. Rice Bowen is diplomatic, yes, as diplomatic as she is vibrant, yes. I think it's probably best left to the discussions that we're gonna have upcoming with Beacon before I can speak to what level of cover and their level of involvement in the fight against colon cancer. Yeah. And I see Dr. Doyle biting his lip with me. He was really wondering if I was gonna go on a lip. Yeah.
I would say that public pressure also would help. So if there's a groundswell of persons really pushing for some of these things, that would help the case as well. Not just from a medical standpoint, because some may say that we're just trying to do it for financial gain, which really and truthfully is not the issue. But if the patients themselves, or potential patients themselves, look to push the issue, then that may help the case as well.
Yeah. Oh, I would also say, by the way, though, may I please add, of those 1,500 kits, I would say at least 600 of those, at least 600 were given away free of cost. And the returns on the ones that were given away free of cost were far lower than the ones where people actually had health-seeking behaviors. Yeah, so I mean, came and asked for them or were choosing to pay for them. So in a sense, it is not always if the service is available. It is also a lot to do with if the service is if persons are willing to accept the studies. And one of the shocking things was that the group that gave the lowest level of returns on the kits for this project scope. We had nice talks with them, they took the kits, they were very good, and then we found out that significant proportion of them were dumped because people didn't want to know. It turned out that the guys were afraid, they didn't want to know. They said, boy, what if you don't know, it can't hurt you. Yeah, they're really worried about finding out some bad news. Yes. And I think all of those issues need to be addressed because in reality, colon cancer is a preventable illness. If we find this thing at the level of a polyp, we can remove the polyp and avoid colon cancer. It is preventable, right? And this is well known. So in truth, a lot of it has to do with persons' desire to actually move ahead and do the testing, more so than the availability of the test or the freeness or the cost, etc. I have another one for you, Doyle. Can doctors give some more info on the CT colonoscopy? Is it less available? And if so, is this test available? Less invasive, sorry. And if so, is this test available?
The test is available on the island, and I believe it is also available in the hospital setting, last I checked. As with anything, there is an issue in terms of when the actual equipment is available. So that may be a limiting factor in terms of being able to access it. It is less invasive than a colonoscopy. You still have to do a bowel prep to clean out the colon before you get the CT scan done. And bowel prep is one of the things that really patients complain about when they're trying to do a colonoscopy. Basically, the bowel prep is a set of medication that you take to really empty the bowel of stool so that if at colonoscopy or during CT colonography, you can actually see the lining of the colon itself. CT colonography is less invasive in that regard. However, like I said, the limitation of the CT colonography is that it doesn't do well in picking up polyps that may be less than 5 millimeters. So smaller polyps that you can see potentially at colonoscopy and remove, depending on the morphology of the polyp. And then the interval in terms of when you would repeat a CT colonography, so it's usually like 5 years. You would repeat it if you don't have any other screening modality done. While for colonoscopy, if it is normal and nothing is found, you can go 10 years before having to repeat it once you don't have any change in your symptoms.
Okay, there's room for one more question. Anyone having any further queries? We have room for one more question. Okay, it seems as if everyone is satisfied with the presentation and what they've learned today. So I now invite our Vice President, Eric Smith, to deliver the closing remarks. Mr. Smith?
Thank you, Celia. Good evening, everyone. On behalf of the organizers, I extend heartfelt thanks to all who made this evening's webinar such a meaningful and informative event. This session, organized by BARC and the Caribbean Colon Cancer Initiative, focus on a matter of growing importance in our society, understanding colon cancer. It is an issue that calls for great awareness, early detection, and open discussion. And these are all critical to saving lives. We're especially grateful to Ms. Cecilia Thompson, Member Services Manager at BARC, for so ably hosting the proceedings. Thanks to you, Madam President Marilyn Rice, for your words of encouragement in your opening remarks. To our presenters, we offer sincere appreciation. To Dr. Alex Doyle, Consultant General Surgeon and Surgical Oncologist, who has worked tirelessly to strengthen colorectal cancer research and treatment in the Caribbean. You brought valuable international training and experience back to Barbados. We are grateful for your contribution in that regard and this evening. To Dr. Brandon Griffith, Junior Research Fellow at the Caribbean Colon Cancer Initiative and Program Coordinator for the Caribbean Society of Endoscopic Surgeons, thanks for your strong commitment and research in this particular area, as well as patient care. We thank you for sharing your knowledge and these perspectives with us. To Dr. Sahle Griffith, Head of the Department of Surgery at the Queen Elizabeth Hospital and Founding Director of the Caribbean Colon Cancer Initiative, you have provided visionary leadership in advancing colorectal care and research in our region. We thank you for your continuous dedication and service. We also acknowledge those who work behind the scenes to ensure the smooth execution of this virtual event. Finally, thanks to everyone who joined us online and participated in the discussion. Your engagement highlights the importance of conversations such as these. Yes, we will be scared, but we must talk. Thank you all. Have a good night, and please continue to be safe.